Good evening, everyone. I'm Neil Love from Research to Practice, and welcome to What I Tell My Patients. As tonight we focus on the management of lung cancer, specifically non-small cell lung cancer. We have a great faculty tonight, and we're really looking forward to making rounds with them, hearing about their patients, and talking a little bit about where we are and where we're heading in this very common cancer. Here are the themes that we have all week long, and we know that even though we're talking about a specific set of tumors, we're talking about lung cancer tonight, a lot of the principles that we're talking about really apply throughout oncology, and we hope it'll be helpful. We're really here mainly to provide a research update to you and your patients about where we are in the management of lung cancer and where we think we might be when you come back to ONS next year. We're also going to present some real cases from our nurse practitioners on the faculty, and there the theme that we're going to get into is the biopsychosocial model, and specifically, why was it different to take care of this patient than another patient with the same oncology situation, but a different person, different value system, socioeconomic status, etc. What was it about taking care of this patient that was different? And finally, we'd like to take a breath also and think a little bit about the bond that we have with our patients and how much that means to them, and also to take a breath and say, what you do is highly, highly valued, and really you should feel great and very happy about what you're doing for patients. So with that, I want to introduce the faculty, and we've had a tradition here at ONS. When we introduce the faculty, we like to ask them what they like to do to get away from the job. You know, we know that it's not the easiest field to be in, a lot of challenges to be in medical oncology, and a key issue is just trying to spend some time away from the job. So Tsao, I'll start out with you. Tell us what you like to do to have fun.
Well, I really like to eat. So I am, and unfortunately I do have a dairy allergy. So, you know, usually I have to find a ton of recipes to substitute in things that I can actually eat. So I started learning how to cook pretty much like 20 years ago. And so during the pandemic, all right, I think for all of us, you know, I didn't know if I needed to join like Weight Watchers or AA after the pandemic, but nevertheless, one of my passions is food and cooking. And so anybody has any great recipes, I'd love to hear it.
Interesting. We've had a couple of foodies here on our faculty. Stephen Liu, you're up in Georgetown. What do you do for fun?
For me, Neil, I'm a movie guy. I studied film in college. I started as a major, actually.
Really?
With a minor, but I'm a big movie guy, and lately more it's my daughter. My daughter's 7 years old, only child, and you know, as soon as I get home, she's attached to me at the hip. She's really a daddy's girl, and if I have a nighttime Zoom or if we're doing something at night, Neil, I can promise you she's under the desk in the book right next to me. So that's generally how I try to distance myself from work.
So Tara Plues, you're in the Cleveland Clinic in Cleveland. What do you do for fun?
I would say that I try to balance out, you know, some of the hard times with some really good times by usually either booking a concert or a trip. I like to go places, and sometimes I just make myself do crazy things like hang gliding or run a half marathon just to prove to myself that I can still do those things. So I also have a 8-year-old daughter, and I'm getting ready to take her to Disney soon. So
good luck with that. Hang gliding, though. I want to see a picture. You got to need next year. I want to see a picture of you hang gliding. So, Jillian, you actually work with Stephen. That's great. It's going to be interesting to present some of your patients that both of you are taking care of tonight. What do you do for fun?
Well, one of my recent things to decompress is actually paint by number. I stumbled across it, love it, can do it for hours, turn on some music in the background, or TV show I've seen a million times. So I really enjoy that. So it gets my kind of creative juices going, and I don't have to actually be great at it. It looks like a work of art. And I love like anything physical activities. Recently, aquaspin is something I've done that I really love. So
awesome. All right, well, here's where we're heading tonight. We're going to start out talking about immunotherapy, and particularly the use of checkpoint inhibitors. And again, we're going to be focusing on non-small cell lung cancer. We also have small cell as well. where we're using checkpoint inhibitors. Then we're going to talk a little bit about a new modality, tumor treating fields. We actually were talking about this today at our lunch program on ovarian cancer. Very interesting form of therapy that we're about to see some new data in lung cancer on, and nobody knows exactly what we're going to see in a few weeks. Then we're going to spend most of the rest of our time talking about targeted treatment. And this has been a real theme for us, and a theme in oncology in general. It really started with lung cancer, and now you see this. I guess was it this morning? We were talking about biliary tract cancers, and I was sort of joking that biliary tract cancers are the new non-small cell lung cancer because they got a whole bunch of mutations there they're treating. And then we're going to go into some examples of the use of targeted therapy in various types of tumor mutations, and also some themes in terms of targeted therapy. But we're going to start out talking about immunotherapy. In a second, we'll hear about Jillian's 79-year-old woman who got immunotherapy with chemotherapy. But let's just take a breath and start out. And it really hasn't been that long. I think it's only been since around 2017 or 16 that we had an approval in lung cancer, which really changed the face of infusion rooms in this country. Prior to the approval for lung cancer, checkpoint inhibitors were only approved in melanoma, much less common. But once they were approved in lung cancer, that became part of the medical oncology infusion room. And it really required a complete difference in mindset for the office staff in terms of the toxicities. We've been used to dealing with chemotherapy for so long. Now we had a completely new modality with a new mechanism of action and new toxicities. What's your vision of how immunotherapy, and particularly checkpoint inhibitors, actually work, Anne? And the theme that we have is here, how do you explain it to patients?
Mm-hmm. So one of the things I first explain to all of my patients is that immunotherapy is not chemotherapy. Immunotherapy essentially revs up your immune system to go after your cancer. And so most patients, then the next normal question is, what are the side effects? And immunotherapy always runs the risk of doing an autoimmune or attacking yourself. And so I try to tell them that they can get inflammation anywhere in the body, but it's a pretty low risk. I'd say a good 80% of my patients live a full, wonderful life, on immunotherapy, doing great.
So, Stephen, I was thinking about some of the commercials you see in TV where they list a million things, but then they don't tell you what Ann just said, which is most of the people don't get these things. But can you talk a little bit about what we've learned about efficacy of immunotherapy, particularly checkpoint inhibitors, and also the question of whether or not when you see someone now, immunotherapy is a standard part of first-line therapy of metastatic disease, and that is how most patients with non-small cell lung cancer typically present. Can you talk about how you think through whether you're going to give just immunotherapy, Stephen, what kind of immunotherapy you're going to use, and in particular, whether you're going to also add chemotherapy?
Well, you're right, Neil. We have a lot of different options and different ways to deliver immunotherapy. As Ann said, immunotherapy is our standard of care for everyone without a driver mutation. And I look at this as something that won't work for everyone, but if it does work, this has the chance to keep working. And unlike other treatments we have, this is a medicine that for some people will never stop working. That's a huge difference from things like chemotherapy, even targeted therapy, but there are different ways to deliver it. We can give one immunotherapy drug alone, we can give two together, we can give them both with doublet chemotherapy, we can give all four drugs. We've got multiple regimens and not a lot of head-to-head comparison. And so choosing between them, we look at features of the tumor, what proteins are on the outside, but also patient characteristics. There are some immunotherapy drugs that are a little more toxic. They're effective, but drugs that target CTLA-4 have some unusual side effects. For that, I really am looking for a partner in a patient, someone that's going to tell me their side effects early. So if they see those side effects, we can reverse them quickly. If someone's not a complainer, if they're not going to really be upfront about what's going on, if they don't have a lot of support system, if they live really far away from my hospital, maybe that's not the best candidate for some of these more intense immunotherapy drugs.
And Ann, in the past, the diagnosis of metastatic non-small cell lung cancer meant your patient was very unlikely to be alive in a couple of years. But we started to see some patients now surviving 5 years, and specifically, even without evidence of progression. but specifically patients who had high PD-1 levels. So can you talk a little bit about what you see in the people who have high PD-1 levels, 50% or higher, compared to low? You can even have zero PD-1. And in particular, in those with high PD-1, what you see and what fraction of these people actually are still doing well 5 years later?
So about 20% of all non-small cell lung cancer will have what we call high PD-L1, which is, PD-L1 is a protein that we can pick up on the tumor expression. And so for those patients, when we give them a single immunotherapy, I have patients right now in my clinic that are 7 years out with stage 4 metastatic lung cancer, even with brain mets at diagnosis, that are continuing to have almost a complete remission and are doing great. And this case, I believe, is one of those examples of that. But usually, when the patients, you have to make a decision oftentimes by, a year and a half about whether you want to continue that immunotherapy. You're going to see a lot of your medical physicians debating how long to keep the immunotherapies on, and the honest answer is we're not sure. But these patients now have a lot of hope in this setting. So for those patients with high PD-L1, they should get an immunotherapy sooner rather than later. In some cases, you will see them getting chemotherapy plus the immunotherapy because immunotherapy takes a little longer to work, and chemotherapy usually can reduce the cancer a lot faster. So that's why you're going to see some variability. Like, it's not one size fits all. Just because they're high PD-L1, if they've got a lot of disease, they're endangered by the disease, they may need to have the chemo plus the immunotherapy, as opposed to somebody that just, maybe they have a lot of little disease everywhere, but they're not endangered. They could probably get away with getting an immunotherapy single agent initially.
So before we hear about this case, just one more question to you, Tara. Stephen referred to, situations where you have more intensive therapy, where you really need the patient and their family to partner with you. And we've heard this over and over now in the last couple of days. And I'm just kind of curious, when you first meet a patient and you're thinking about maybe we're going to, offer the opportunity of a more complicated therapy, how do you sort of assess whether or not the patient's going to be, quote, a good partner in working with you?
Well, I do think that's a good word. I do try to assess, the patient and try to figure out if more information would be better or less information would be better. I think sometimes when you read, a laundry list of possible side effects, either A, they get into their head that they're going to get all of them, or B, they just get really overwhelmed. And so I usually, try to tell people these are the more common things that we see, maybe some joint aches, some itchiness, some mild skin rashes, and there's a smaller chance of having some more significant side effects, but those chances are pretty low. If there's anything that's, bothering you or concerning you that you feel is not manageable, I need you to call me so we can talk about it over the phone, so we can further assess these symptoms. So I try to keep things more in generalities.
So Jillian, let's hear about your 79-year-old woman. You were telling me that she was one of the first patients that you took care of when you came and joined the service there, the lung cancer service there. That was around 9 years ago. Mm-hmm. What do you remember about this woman when she first presented?
So this 79-year-old metastatic non-small cell lung cancer patient is a practicing physician. So one of the things that I always do when I meet a patient for the first time is assess their needs outside of just their medical care. And she was someone that wanted a lot of information. She had done research herself, and she was making specific requests. And so wanting to maintain her practice as a physician, it was very important that she had a regimen that she felt like that she could manage. Also, she did not want others to know that she had this disease. So it was important to her, is this something that's going to make me lose my hair? Am I going to look sick? So that was something that we considered. This was a clinical trial, and this combination of chemotherapy with the atezolizumab, generally well tolerated. Fortunately, she had a great response. And from that, she's been on the maintenance therapy for now 9 years, and she really hasn't had any significant toxicity. Now, that is unusual to be on for that long. And I think something that's been mentioned is that there's still the question of how long do you need to be on this for it to still be active in your body, and I think that we're learning more and more about that as time.
So certainly it's different to be taking care of a physician, but you also had mentioned to me she was taking care of her mother as well?
Right, so not only was she a practicing physician, but she also was taking the primary caretaker of an elderly, her mother. So she was juggling quite a bit of things. So it was necessary for her to be in a position where she could still be available to the different people that she was taking care of in her profession and as well as personal. So we were, very fortunate to have this available to her. This was back in 2014 when it was a clinical trial, and for it to be effective and manageable, she was able to tolerate it, was a great thing that we were able to offer her.
And I should mention, you mentioned her mother's 100 years old?
Yes, so
Maybe she will be too sometime in the future. I'm curious, another theme that we've talked about is participation in clinical trials and the potential advantage of it. We presented a number of cases now in the last few days where drugs that got approved, we presented cases of patients who'd been on it for 2 years before it was approved. They were on a clinical trial. She obviously got a therapy 2014 that was not available, wouldn't have become available for several years after that. I mean, checkpoint inhibitors are fairly new, actually, in medical oncology. From the point of view of taking care of a patient with metastatic lung cancer as a physician, how was that?
So I think that we've all probably taken care of other healthcare providers, and they have a strong knowledge base, and there may be specific things that they ask. So it's learning how to respect their wishes, understanding what they know, what they're aware of. And I think actually now we have more of an educated, many of our patients now are much more educated, and they don't have to be in the healthcare field. So I think all of us are looking to meet the needs of our patients, and so that can be a very individual approach. Some people want a lot of information, some people want very little, and in this case, this was someone who wanted to know a lot. She was involved in the steps of her care, so just respecting that, what she needed.
We were talking about lung cancer actually last night. We did a session on HER2 positive disease across tumor lines. So we had lung cancer people, breast cancer people, GI cancer people last night, and one of the lung people, Kelly Goodwin from MGH, was there also, and she was talking about the issue of how people feel about getting lung cancer when they're first diagnosed and how that varies based on, was she a smoker or non-smoker? It's been so long you may not remember.
I don't think she was. If she was, it was a distant smoker. It wasn't something that she was active. An active smoker, no.
And what do you see in terms of how people respond to the idea of being in a clinical trial? Here's a patient who had tremendous benefit by being in a clinical trial. What kind of response do you get? And also, we've talked a little bit about variations in cultural and socioeconomic access to clinical trials. Any thoughts about that?
Yeah, the response that this patient had is really unusual. The majority of people diagnosed with lung cancer do not want to be a guinea pig, is usually what we hear. And then when we explain to them how this works, people always ask, well, is this a phase 1 trial? Is this like first in human? And I'm like, no, this is like way down the line, but people still don't quite have that understanding. So it's so critical for all of us to educate our patients. I would just like to say, though, I apologize to any future physician I have because I know I'm going to be horrible as a patient. But, giving your patients that time to say, clinical trials are opportunities to get you the latest drugs that we know can potentially be effective for you, is more how I try to get all of our staff and all of our clinic to focus on our patients to teach them that.
So, Stephen, part of the reason we try to go through the granularity of how oncologists think through decisions and sort through the therapies is often it's not that clear what to do. When we're going to the AUA meeting on Sunday and we're showing a survey of investigators on what they do in clinical scenarios. And sometimes they all do the same thing, and sometimes you see 4 or 5 different things that they do, and you know that it's not that clear. And one of the things we've talked about is if you're in a situation where you're not really sure what the right answer is, allow the patient to, if they want. You have a patient who's a physician who certainly has the ability to understand that. And, and a good example of that, when we were in the planning room before you came in and we were talking about this case, and Jillian said, oh, she's been on checkpoint here for 9 years, and everyone went, whoa, 9 years? Usually people, I think in the trials, they stopped at 2 years. What happened? She wanted to keep going, I guess. Is that the idea?
Yes.
So, we don't really know. We had a case presented at the SGO meeting a few weeks ago. The patient was just getting to 2 years. The doc was thinking about stopping therapy, starting to talk to her, and she relapsed. And that's a terrible scenario if you stop and then you see a relapse. Any thoughts about this decision and how it occurred in this lady? And in general, how you think through this very difficult question of, do you stop therapy, for example, at 2 years, or you continue it? And if the patient wants to continue, it sounds like, at least in this case, you were open to that.
Yeah, the stakes are pretty high, and there's a lot we don't know. You're right. In the current landscape, when we start with immunotherapy, PD-1 inhibitor, PD-L1 inhibitor, chemo or no, the general plan is 2 years. And our thought is after 2 years, if we stop without disease progression, we should be able to maintain that patient without progression going forward. But we've learned a lot over time, and we know that that's not absolute, and we do see late relapses even after we stop. She actually was on the phase 1 study of this combination, and we got a memo for this that said, hey, we can stop at 2 years, but she was already about 4.5 years in. And so she said, I feel fine. She had no side effects. She had an amazing response. She did not think she'd still be alive. And so it was more of a, if it's not broke, don't fix it approach. She wasn't having any side effects. And, for me in this situation, I'm pretty good at saying, I don't know. Practice makes perfect. I don't know what the optimal duration is. And I think probably it's going to be different for everybody. There are some people that might only need a couple doses, and maybe some that need continuous dosing. But she flat out directly asked me, if we stop and it comes back, can we restart? And I said, yes. If we restart, is it going to work again? I said, maybe. Response rates are around 50%. And it depends on if you're a glass half full or half empty. Wasn't good enough for her, so she wanted to continue.
I'm kind of curious. We're starting to see, we've already talked about it a couple of times with other tumors this week, the idea of looking at so-called cell-free DNA. It's being done right now in colon cancer, and people are making decisions. And the idea is you can detect the DNA of the tumor before you see anything on scan, anything. It's very, very early. And in colon cancer, they're already using it to decide whether to use chemotherapy. What about using that kind of strategy in this situation as you get out to 2 years in clinical trials, looking at whether or not they have residual disease, or you think you wouldn't see anything?
It's something that hasn't really been explored too much in lung cancer. We don't know. Those colon cancer data are really great. In melanoma, they're using PET scans to sort of guide stopping therapy. We don't really have similar approaches in lung cancer yet. If we stop therapy, cancer comes back and we restart, would it have come back anyways, even if we had continued treatment? I don't know. I don't know the answers to those. And so while 2 years is, I think, the standard, I don't think I'm doing harm by continuing. So if patients are really insistent, really prefer to continue therapy, I involve them in the decision, and I'm okay with it. I do bring it up every so often. She kind of rolls her eyes at me still, but we're still going. Is Ann glaring at me? I feel over here. Something's coming from over here.
Anyhow, I'm sort of flipping through some of the slides. You can check them out later. That some of the key studies. I guess one thing to mention is there are a number of checkpoint inhibitors that have been studied in lung cancer, either alone or with chemotherapy. The other, and I think you alluded to this a little bit, Stephen, is the idea of combination immunotherapy. And we've already talked about that. For example, hepatocellular cancer now. You have a regimen with so-called anti-CTLA-4 and PD-1. And we're about to hear about a case where that was used. One of the times that I hear people talking about it is people with low PD-1s, where you really don't expect benefit from just a regular IO. Do you ever use that strategy? And do you see more immune toxicity when you use 2 checkpoint inhibitors?
Well, so usually when we're combining, at least in non-small cell lung cancer, we're using usually one of the checkpoints that targets PD-1, PD-L1, and then we're using a CTLA-4 inhibitor. Now, those we generally do see more diarrhea, and we do see an uptick in some of the different autoimmune toxicities. So combining them, absolutely, you do get an additive effect, and so that's important to know. I'll be honest, sometimes I will start them on the 2 checkpoint inhibitors, the CTLA-4 inhibitor and then the PD-1 inhibitor, and then I have to drop the CTLA-4 inhibitor because of toxicity. So that's actually a pretty common strategy that we do.
So before we hear about this case, maybe just to provide a little bit of an overview of the type of autoimmune toxicity that we see. There's another issue that we'll hear about with this case. But Stephen, I hear people saying if it ends in itis, you can see it. And this is a typical type of diagram that people talk about. Can you kind of provide an overview of what you typically see? What are the more common autoimmune problems? And also how you just, what do you do if a patient already has an autoimmune disease? Yeah. They have psoriasis, they have Crohn's disease. Can you give a checkpoint inhibitor?
Yeah, that's a good point. This is where most of the discussion is. I think the efficacy part, that high ceiling, people get that right away. The side effects, like Ann said, if we're revving up our immune system, we want to rev up the immune cells that'll fight cancer. But we're probably going to rev up a whole bunch of other ones along the way. And any part of your body that your immune system has access to can be a source of side effects, and that's the entire body. So really, head to toe, anything. My approach is if someone comes in with something new, I'm going to assume it's from something that I did until proven otherwise. Some common ones are just lab abnormalities. Those are easy. Liver blood tests, those are paper toxicities. Patients generally don't feel those. But if they're high enough, we have to stop therapy, give steroids, reverse that. Depending on how high they were, we might restart or we might not. The ones we worry about in lung really are pneumonitis, myocarditis, things that manifest with a lot of shortness of breath that can be sudden. These are no joke, and people can die if we don't pay attention to these quickly. So if we have a severe case of any organ-related immune side effects, it's steroids right away, and hopefully we can reverse that. But we tell patients that generally I expect you to have some side effects, but I don't expect them to be too severe, and we're going to watch closely so we catch them early.
Tara, what are the typical things you see? One of the things I hear about, not that it's that big a deal, but you hear a lot of people getting is dermatologic issues. What do you see there in terms of the skin?
There's definitely a lot of skin rashes, exacerbations of either eczema, psoriasis, or just new rashes that they've developed on immunotherapy. We also tend to see quite a bit of colitis and pneumonitis. I think those are the more common, of the middle of the road.
When you see a patient who has diarrhea, and there are so many situations, so many agents right now that cause diarrhea and other conditions that can cause diarrhea, how do you sort of sort it through and work the patient up to figure out whether it's because of the checkpoint inhibitor or something else?
Most of the time, I feel like it declares itself. It tends to be kind of abrupt onset and bothersome enough where it's multiple episodes a day where you're not really questioning it too much.
And another thing that's very common are endocrine abnormalities, as you can see on the left side here, particularly thyroid, hypothyroid, hyperthyroid. And really the best way to pick this up is on blood work. Can you talk about the type of blood work you do and how long you do it for? If you stop the immunotherapy, do you need to continue to watch the thyroid?
Yeah, so you should always be checking a TSH and a free T4. And usually when I first start an immunotherapy, I get a baseline before I begin, and then I'm usually checking every other cycle, which is usually every 2-3 months. Now, once I stop the immunotherapy, I will still check that thyroid function. And you have to continuously monitor because I have found the most common side effect usually is going to be thyroiditis. And you really do have to stay on top of this because these patients basically get hyperthyroid and then they sort of burn out and they become hypothyroid. Mm-hmm. And then they need lifelong synthroid replacement or thyroid hormone replacement, your choice of whatever you want to choose. But usually I will continue to check thyroid function for up to a year after. Some people say that that's not necessary, but I have OCD and my patients understand and accommodate. So,
Stephen, you had a thought?
Yeah, I think that we have this long list of side effects. What we try to tell patients once they start glazing over a little is that consistently immunotherapy is better tolerated than chemotherapy. And generally these are safe drugs. One important side effect, though, that we don't talk about a lot is that immunotherapy, for very complex reasons, PD-1 and PD-L1 inhibitors will completely disable your response to Mycobacteria TB. So if someone has latent tuberculosis, you give them a checkpoint inhibitor, you're really looking at a concern for reactivation. And in fact, in a lot of cases where TB is endemic, pneumonitis, colitis, at autopsy, those fatal cases are often just miliary TB. So if someone has a history of TB or that exposure, you really need to test and make sure. And if they do have sort of latent TB, if you're going to give a drug like this, you really got to keep them on suppression.
I feel like I've asked a million people about checkpoint inhibitors. I never heard that. That is fascinating. Have you actually seen a case like that, Stephen?
Have.
Really? Wow.
Yeah, we wrote that one up. That didn't end well, sort of when we caught this up. But there's some very elegant mouse work at the NCI that shows exactly how it happens. It's not a common thing in the U.S. I suspect it's underreported overseas, though.
So another issue, Jillian, that we were talking about today, we actually had a case that we were talking about of a patient who was on a checkpoint inhibitor. This is in North Carolina, in the rural area, went to an emergency room for diarrhea, and the patient got admitted, got antibiotics, got antifungals, and the docs in the hospital, and then the patient came back to the oncologist and told the story, and the oncologist almost had a heart attack because she had autoimmune colitis. Any thoughts about, and we were talking about the fact that it's very important to educate our non-oncology colleagues about immunotherapy, at least basically to know what it is. And then we were also talking about how important it is for the patient to understand. We talk about, patients have tags and stuff saying that they're diabetic, et cetera, but they need to know when they go to the ER what's going on and what the therapy is and the kind of toxicities that they might have. Any thoughts about that? Have you seen patients get out into a non-oncology situation like that and, deal with people who are really not familiar with this?
Well, I really try to educate our patients so that doesn't happen. So when I'm talking to a patient that's about to start the therapy, I do talk about the possible toxicities, but one thing that I always say is, if you have to go to the emergency room, you're not coming to us, let them know you're on immunotherapy. Scribble it down, put it, some people keep stuff in their phones, some old school in their wallets, but have that so that you can present it so that they know I'm on this type of therapy, because typically, steroids is a nice place to start for most of these itises. And so if we can get that started, we can, prevent a lot of things going under the radar.
So Stephen, you also mentioned that usually the first therapy, when you have an autoimmune toxicity, a corticosteroid, trying to damp down the immune response. But what about patients who've had transplants? Where they're having their immune suppression because now they have a solid organ transplant, and you're looking at potentially the risk of rejection, and that's actually leads into the next case. Now, if you've had a kidney transplant and it's rejected, theoretically you can go on dialysis. If you've had a liver transplant, and we were talking about HCC, hepatocellular cancer this morning, where they do that, or you've had a heart transplant, you cannot afford to have it rejected. How do you think through the issue? We're about to hear about a case. Talk about very, very difficult decisions that you want the patient involved. Tara has a patient who actually, because of a past history of renal cell cancer, had a kidney transplant and then developed PD-1 low non-small cell lung cancer. What about transplants and IOs, Stephen?
Yeah, so these are the hard cases where oncology is more of an art than a science. And when we look at immunotherapy and other conditions where our immune system is already too active, you can't have it both ways. We can't suppress the immune system for this part and activate it for this part. We're just not that advanced yet. We're not that selective. It's either all on or all off. And for those things, whether it's a transplant or a severe autoimmune condition, it's risk-benefit, and ultimately the patient's sort of the ultimate arbiter. Now, at the same time, I think as a physician, we can't do things that I know are going to lead to harm. So if someone did have a heart transplant, I don't think that's a case where I'm going to be willing to go. Even if he's willing to take that risk, I'm not. But in cases where it's a multiple sclerosis flare, it's a severe lupus flare, it would be rejection of a kidney. I think if there's a clear understanding of the risks and the worst case, I think that it's something that I try to make the decision with the patient.
Yeah, I mean, if you're looking at, a diagnosis that is going downhill, you're looking at a 6-month or a year survival to take a chance, and certainly the patient has to be aware of what the risks are, but it seems like it'd be reasonable. We were talking about a case we had a patient presented who did have multiple sclerosis, an autoimmune condition, and patient had, a metastatic lung cancer. They sought a second opinion. They all knew what the risk was. Could have had a severe exacerbation of the multiple sclerosis. They gave the patient an IO. The patient responded, MS, no problem. So you never know what's going to happen. What happened with this 59-year-old man, Tara?
So this particular gentleman, he presented with metastatic non-small cell cancer, and he had a pretty extensive medical history. He had a history of cirrhosis with chronic hep C. He had a renal cell carcinoma that required a kidney transplant. He had a history of portal hypertension and left ventricular hypertrophy. So he had quite an extensive history, and he had just lost his wife also from cancer a year prior to his diagnosis. So he had a lot of things going on. And when he came, the physician and him had a pretty clear conversation about the risks, associated with chemo and also with immunotherapy. The physician felt strongly that he didn't think chemo would be as effective for him because he was a transplant patient. And so his recommendation was to go ahead with the ipilimumab, nivolumab, but they had a conversation that the risk of rejection of that kidney would be about 40 to 50%. And the patient agreed that he thought that was the best option as well. And so he started on the ipi-nivo. He had 1 dose, and then I saw him for his second part of cycle 1. And the day that I saw him, his creatinine had more than doubled. So he was admitted to the hospital. He was rejecting his kidney. He was started on steroids, and then he was started on dialysis soon thereafter. So he's currently still on dialysis, but he wound up having a really good, really pretty decent, at least 50% response on imaging to the ipi-nivo, and he's been on it for 10 months, and he's surprisingly doing really well. He clinically looks really good, and he had a good response, so we're still going.
What was it like? What's it been like to take care of him? How did you feel when you saw his creatinine going up, and how do you feel now about taking care of him?
Well, the day that his creatinine went up, I felt sick because I felt like we had done this. And, that happens sometimes. But, I felt like we had made that decision together. We had a really very clear conversation about it before we started. And so, now that time has gone by and he's been doing really well, I think that we feel a little bit more comfortable with our decision. He's a really nice, interesting man, and I enjoy seeing him for visits.
Interesting. So I want to bring up another topic before we move on, and we're going to talk a little bit more about checkpoint inhibitors, and then we're going to get into targeted therapy and spend most of our time on that because there's a lot to talk about in terms of targeted therapy. But Stephen, I wanted to sort of pick your brain and also the whole faculty here, and we mentioned this today in the ovary program, that at the annual ASCO meeting is coming up in a few weeks, we know because there was a press release that came out that we're going to show you in a second, and this typically happens in oncology all the time. If there is an important trial, usually they'll put out a press release. They won't put very much data in it, just saying the trial is positive, get ready to see the data. Now that we're going to see the data here, we don't know the magnitude of the benefit. We know that it was a positive trial. There have been a bunch of things that are going to be presented at ASCO where we don't know what they're going to do. They always embargo it, but we know it's a positive study. First of all, can you talk a little bit? I know there's very little experience in the United States. Mainly it's with brain tumors, glioblastoma, where actually Tumor Treating Fields is approved. It's also approved in mesothelioma, which is seen by pulmonary oncology physicians. But this is a very different type of therapy, Stephen. I like the idea that it's different, but it is very different. Can you talk about your vision about what Tumor Treating Fields is, and what are you thinking about as we get ready to see this new presentation?
It's a very new modality. You know, we are expecting the phase 3 LUNAR results. Dr. Tsao will present that as an oral abstract. There's only about 9 or 10 oral abstracts. So in that setting, we know that it's more than just a positive trial. It really is probably big news if it made the cut there. This is really the application of alternating electrical fields, and there are lots of different ways to disrupt cell growth in a controlled manner. Chemotherapy is one way that we're familiar with. Radiation is another way. Electrical fields is a different way to do that. Now, how do we deliver those? That's the challenge, because we can't deliver them from afar. And so in glioblastoma, in brain tumors, really it is wearing a cap connected to a battery that you sort of wear in a backpack, and that's delivering the treatment sort of while you're walking around, while you're living your day-to-day. For mesothelioma, it is a vest that's sort of delivering the electrical currents through the chest, and has been effective, and as you mentioned, is approved in both of those tumor types. Lung cancer, a much more common tumor type, how effective will it be? How much will it add to the other treatment? And in which patients is it really going to work? That's really what we're looking forward to seeing at ASCO.
And here's the press release that we saw in January, raising this awareness. And can you comment a little bit about what you know about this? We actually did a webinar with your colleague in neuro-oncology, Chirag Patel, because I saw a whole bunch of papers he wrote looking at, a lot of translational work. And we had him on a webinar just trying to explain his vision of how this worked. And it seems very different and very interesting. There are also practical issues that have to be considered. What's your take on this, Anne?
Yeah, well, I think Stephen summarized it beautifully, right? There's a lot that we don't know, but the current prevailing thought is that when you are able to create these electric fields, like you wear basically an adhesive patch, and then you've got these transponders, and then you create this electric field, and you can adjust the frequency, and that somehow disrupts cell mitosis. Now, this by itself, because, of course, all of us are now, oh my God, am I going to get like cancer or disruption of my cells if I go stand next to an electrical appliance? No, it has to be given in conjunction with a systemic therapy. So in the LUNAR trial, they were looking at patients who were receiving chemotherapy, docetaxel, or immunotherapies. And so when the results are presented, they're going to be talking about those different subsets. So you have to give a systemic therapy in order for this device to work. Same thing for glioblastoma. So whenever you've got two different types of treatments ongoing, and one is like essentially a physics equipment, it's really hard to tease out what are the independent contributors to this anti-tumor effect. So that's why you're going to see, I expect, a lot of people scratching their heads going, okay, we see the clinical results that in the press release it states an overall survival benefit. What does it mean? And was it really the chemo or the immunotherapy? And so I think the honest answer is I'm predicting that a lot of people are going to demand to have more information and more trials before we can actually adopt this into clinical practice. But it's already FDA approved in glioblastoma. It already has an indication in mesothelioma. I think non-small cell lung cancer, maybe even ovarian, we may start to see that this is becoming more and more adopted, and we'll start to see it being utilized in the US.
So, and I guess one of the things that we have heard from the people who've used it, it doesn't seem to have systemic toxicity, but the actual skin can be irritated. And I know they're kind of trying to come up with smaller devices and smaller batteries so you can walk around more comfortably.
Yeah, I think the batteries, I think it's only like 2.5, 3 pounds, so it's actually quite light. The skin tox, it's redness, and it's usually skin toxicity from the adhesive material, the little gel that you have to attach the transponders to. So I think they're trying to work on a better, I guess it's glue. So oncology, we're always the eternal optimists. We'll see what happens. The skeptics will say, oh, well, maybe the data is not going to be that impressive. And as Ann said, in ovary too, they're combining it with chemo, paclitaxel. So maybe it'll be all debated, but who knows? Maybe it's going to be a huge hit, and all of a sudden we're going to be like, well, how do we start doing this en masse? I mean, that's what happened with checkpoint inhibitors. Originally, it was just approved in melanoma, not that many cases, but I think it was only 2017, I think, when you saw the approval, and all of a sudden, because lung cancer is so common, that became oncology. So,
who knows, maybe we'll be a year from now talking about all the different ways you can use tumor treating fields. To be continued. All right, let's talk a little bit about targeted therapy. To get into it, and kind of as a bridge, because this patient also got immunotherapy, and interestingly, adjuvant immunotherapy. This is a 75-year-old woman, Jillian, I guess, who initially was treated outside and then came to you. But prior to coming to you, I know this patient actually got an IO, pembrolizumab, in the adjuvant setting. You can talk a little bit about this woman and sort of what happened to her.
So, as mentioned, she came from, she relocated and became our patient. And she had been on pembrolizumab for about 2 years. And then we saw progression of disease. We discovered this Exon 14 mutation and started capmatinib. Very promising, to have this targeted therapy to use, but it comes with side effects, toxicities, and the primary thing that she had that was quite significant was fluid retention, edema, significant so that it was described as anasarca. Just not as functional as normal. We tried diuretics to see if that would help. What essentially happened was, holding the medication for a period of time. The edema improved, but did not completely resolve. There were dose reductions, so it was effective, but the toxicities were not well tolerated. So that's something that, a challenge that you have with this is you have something that's effective treating the disease, but are the toxicities tolerable? And working with Dr. Liu, I think one of the things that I've inherited is what is good therapy? It's not just treating the cancer, you're treating the whole patient. And so if we're giving you whatever treatment and it works wonderfully, but you can't get out of the bed, are we doing the best job? And so you have to evaluate from a larger standpoint and not just particularly, what does the imaging say?
So we're going to use this case as a transition from talking about immunotherapy to targeted therapy. But first, I want to thank Carol and April for telling me that ONS has an immunotherapy card that can be given to patients and has their name, diagnosis, type of immunotherapy, physician contact. So that type of approach now makes a lot of sense. Before we get into the targeted therapy, just a word about using checkpoint inhibitors earlier on in the adjuvant and neoadjuvant situation. Because, Stephen, now we have trials showing there's benefit. This woman, got the benefit, whatever that benefit was, but she was treated before it really came in practice. Right now, we have 2 trials that have shown benefit in the adjuvant situation. The first was atezolizumab, which was approved, but also pembrolizumab showing very similar data. But on top of that, so the adjuvant is post-op. They've had their primary lung tumor removed. Now it's at post-op adjuvant, but also, Stephen, neoadjuvant therapy. So the use of nivolumab with chemotherapy prior to surgery to shrink the tumor down, get you benefit not only with metastatic disease, but in the primary. Can you talk again, this is oncology, multiple options, what do you do? I think in the last couple of years, the docs have really struggled. Do you use neoadjuvant? Do you use adjuvant? Which agent do you use? Any comments about what you're doing at your place, Stephen?
Well, it really is individualized to the specific case. When we talk about someone with an earlier stage lung cancer, we want to find these earlier, and our goal is cure from the beginning. We think the best way to cure an early stage lung cancer is surgery, but surgery alone doesn't cure most people with lung cancer, especially if it's stage 2 or stage 3. So historically, we've been doing chemotherapy, but chemotherapy offers a pretty modest benefit, about 5% at 5 years. The addition of immunotherapy after chemotherapy for some patients does improve survival. And so that's emerged as our standard of care. But as you mentioned, giving it earlier seemed to shrink the cancers. And sometimes we would still see a tumor on the CT before surgery, but when we take that tumor out, go to the lab, we don't see any living cancer left. We have a complete response. Those patients do extremely well. We think those patients are most likely to be cured. There are newer studies now, just reported a few weeks ago showing that if you give immunotherapy after surgery and before surgery, that there we get pretty good outcomes as well. So we're using immunotherapy more and more. For us, if we know that these lymph nodes in the center are involved, we don't start with surgery, we start with medicines. And in the past, that's been chemotherapy and radiation, more recently, chemotherapy and immunotherapy. And so that's generally where we'll start. But as we're talking about immunotherapy and targeted therapy, it's important to remind ourselves that these two worlds don't really mix. And if we're thinking of immunotherapy around the time of surgery, we want to be really sure that we're not going to do targeted therapy because we don't want to give those things together.
And that's, I think, a general principle, and in general, that before you start treatment, you want to know whether or not a patient has a mutation. But sometimes it takes a little while, a couple of weeks, to actually get that data back. I'm curious how you approach this issue in terms of targeted therapy versus immunotherapy in general. And maybe, Ann, you can kind of begin to give us a little bit of an overview of what targeted therapy available right now. There are multiple different targets. Most of us have heard about EGFR, currently osimertinib, the most common agent used there. First used with metastatic disease, most patients will respond. Now being used in the adjuvant setting, the only target. We're going to hear a case of that in a second. And can you again provide a little bit of an overview of how you and MD Anderson approach the issue, first of all, of immunotherapy in the neoadjuvant and adjuvant setting? Can you ever use immunotherapy and chemotherapy to shrink a tumor down and make surgery safer, for example?
Yes, absolutely. So this is like one of the big paradigm shifts in lung cancer that's been, I think, really impactful at increasing cure rates. Because almost all of the prior things that we've done over the last decade have been to prolong survival in the metastatic setting. But now we're finally beginning to see the benefit where we're curing lung cancers. So test every lung cancer patient, because you have to know if they are being driven by what we call the oncogenic driver mutations. That's EGFR, ALK, MET, RET, KRAS, and we can talk more about that later, but there's different types of KRAS alterations as well. And then there's also NTRK and ROS1. I'm probably missing one off the top of my head, but these are critical to know because we now have pills that can target these genetic mutations. The reason you have to know before you give somebody chemo, immunotherapy, or even immunotherapy is that many of these targeted therapy drugs are what we call small molecule inhibitors or pills. They can have a pretty deadly interaction if the patient gets immunotherapy first, and then you give them that targeted pill. So we have seen extremely high rates, up to about 25% of fatal pneumonitis when that happens. So you have to know what kind of a lung cancer your patients have. That's why every single lung cancer patient now, even in the early stage, should be tested. Because we now, in the case we're going to talk about, are giving targeted therapies in EGFR mutant patients who get surgical resection. So you never want to give that patient neoadjuvant immunotherapy with chemo, because you can totally mess them up for later on when they need the adjuvant osimertinib.
And one of the things that we've emphasized with oncologists over the last couple of years, because sometimes patients with lung cancer will be very ill and really need to be treated right away, and it may take a week or two to get the tests back for targeted. So what do you do? And Stephen, the word that we've been putting out from you all is, okay, if they really need to be treated, start the chemo, but hold the immune therapy until you're sure they don't have a targetable mutation. Is that kind of the way you approach it?
Absolutely. You've done a great job with that, to your credit, from the very beginning, and it's still something a lot of people don't understand. This is a totally different paradigm. In the past, we'd give chemotherapy, it's not working, too many side effects, stop, wait a couple weeks, clean slate, you're starting all over. It's not true with immunotherapy. When we give immunotherapy, whether it works on the cancer or not, it's changing the immune system in some ways. And the whole point of immunotherapy is durability. So you're changing that immune system forever. So everything you give afterwards might be a little different. If you give an EGFR inhibitor at the beginning, very well tolerated. If you give it after immunotherapy, now it's very different. And like Ann said, these can be sometimes fatal toxicities.
So we're going to start hearing other cases of targeted therapy. But Ann, can you just comment on what we just heard about the CMET and the capmatinib? and also the tolerability issues that you see as was seen with this patient?
Yeah, I'll be honest. I hate that drug. It is like the nightmare targeted therapy drug for me, mostly because first of all, you always got to watch out for liver toxicities. See, even the world agrees with me. It's a terrible drug.
Why don't you just say what you think, Ann?
Yeah, so it basically is one that patients develop a lot of fatigue, GI effects. You can also see like this weird edema. Like most all patients get puffy, but it's like to the point where they're uncomfortable. They're taking diuretics, that compromises their renal function. Then if you have liver, tox on top of that, it's just a problem. Now, with that said, capmatinib and tepotinib are FDA approved for our patients who have c-MET mutations in the exon 14 skipping mutations is what we call them. And they can, in some of your patients, have remarkable responses. But you just have to anticipate you're going to dose reduce them, and you're going to be spending a lot of time managing their symptoms.
Well, it's also not like IV treatment or chemo with once it's in, you can't take it back, because in oral therapy, people can decide if they are not, the risk benefit's not worth it. We should also mention that when we talk about these mutations, these are somatic mutations. These are mutations in the tumor. These are not germline mutations. We were talking about BRCA, for example, today in the ovary session. But these are mutations in the tumor, and these targeted treatments are specific to these mutations. And one of the big questions about targeted therapy, Stephen, is whether or not you use it before chemo and IO. And that has become standard for many of these. For example, EGFR, they don't get chemo and IO first line. They get osimertinib. ALK, they're going to get one of the ALK inhibitors. We're going to hear about a case in a second. When you think through the spectrum of targeted therapy, Stephen, are all these drugs used first line, or only the ones that really have higher response rates?
Yeah, targeted therapy comes in all different flavors, and there are some that work so well. If you look at the ALK inhibitors, like you mentioned, some will work on average from the beginning for 5 years. You've got someone with a stage 4 lung cancer, brain metastases, you start a pill, you have some confidence this could last 5 years or more. That's really remarkable. A lot of other ones, like the MET inhibitors, you're looking more in that 9-month range, and so there's different flavors. Some of the drugs are earlier generation. We need to do a better job with trials and trying to develop newer drugs around there. For the most part, we try to give targeted therapy first. There are a few where they're approved as treatment number 2. That would be HER2, KRAS, G12C, EGFR exon 20. So there are some where they're not approved as the front treatment. In general, though, we want to give them before immunotherapy. One exception would be the KRAS G12C. That's a mutation that's a lot more common in smokers, people with a smoking history. And we know that for those tumors with the G12C, some of those patients probably will be cured with immunotherapy. So we don't want to gamble that. When we think of targeted therapy and these biomarkers, which are so important for all patients with lung cancer, they tell us, 1, targeted therapy will work, and 2, immunotherapy won't work. So it makes the decision easy. KRAS is a little different because immunotherapy can work for KRAS, so we start with immunotherapy there.
So another issue with a spectrum of targeted therapy, Ann, is the issue of brain metastases. Mm-hmm. And again, we've talked about this already in our breast cancer session. The idea of when you have people who have brain mets, the usual treatment is surgery to either take it out or radiation therapy, something local to the brain. But what really started with lung cancer, and now you see it in other cancers, is the idea if the patient is neurologically stable, just treat with systemic therapy, hold off on radiation. Particularly whole brain radiation can have a lot of toxicity. How often do you embrace that type of strategy, Ann? And again, will you do it for all these targeted therapies or only the more effective ones?
So you'll see now all of the drugs, the small molecule inhibitors for the targeted therapies, all for the most part cross the blood-brain barrier, because this is one of the biggest problems that lead to the death of your patients now. The longer that they're living, the more likely they are to get brain mets. Those with, for instance, EGFR mutations or ALK routinely will present to you with brain mets. Now, it used to be some of the earlier first-generation drugs for both ALK, crizotinib, and then for EGFR, which was gefitinib and erlotinib. Those drugs did not have very good blood-brain barrier penetrance. All of the subsequent second, third, fourth generation targeted therapies, though, do cross the blood-brain barrier. So you can see pretty remarkable responses. And we could also see prolongation of time before first brain mets in these patients. So it's definitely one of the biggest, perhaps underrated effects that we've seen. But, we now used to go from 9 months median survival for lung cancer to routinely, commonly having 4, 5, 6 years, where patients are doing great with great functional status and great quality of life.
So, of course, one of the hopes when we start targeted therapy that the patient's going to fall into the category of somebody who has a prolonged response. And this 24-year-old man, that's a pretty young patient, but having lung cancer, has been taken care of by Tara. We're going to hear about that in a second. But Stephen, this patient had an ALK rearrangement. Can you explain what that is and where we are today in treating ALK-positive lung cancer?
So rearrangements or gene fusions are when chromosomes sort of rearrange themselves in a different order, and this leads to a cell that's growing too quickly, that's not behaving the rules. ALK rearrangements or ALK fusions occur in about 5% of patients, a little more common in non-smokers, a lot more common in non-smokers. They can occur in smokers as well. And for these tumors, they are a lot more likely to spread to the brain. We have 5 drugs approved in the US, another one approved in China, that are ALK inhibitors. These are pills taken once or twice a day. They work remarkably well. The 3 latest ones that we have, alectinib, brigatinib, lorlatinib, we take these pills. They work for almost everyone. They work for years, on average 3 to 5 years. That's on average, some even longer, and they're generally very well tolerated. They each have their own different side effects and different profiles. Some have pros and cons with different choices, but this, I think, is our greatest success in targeted therapy, where our survival, a couple years ago out of Colorado, average survival was over 8 years.
So we were talking yesterday in the CLL section about Bruton's tyrosine kinase inhibitors, how they revolutionized the field, but also how as time has gone on, we've gotten more specific, less toxic agents, and are even more second generation, now third generation. And as you were saying, now we have 5 different drugs, ALK. One of the drugs that's really interesting there, Anne, is the most recent one, and really actually in a way some of the most impressive results with a drug called lorlatinib, particularly effective in the brain. But the interesting thing, and I don't remember hearing this anywhere in oncology, is sort of the weird sort of psychiatric symptoms that you see with this drug. Can you comment on that? I hear all these stories that the spouse comes in and says, my husband, my wife's not acting right. What do you see with this drug?
Yeah, so this actually affects your moods. Which is not like the usual thing that you expect. But again, highly efficacious in the brain, so it completely dissolves any brain mets they may have. But, I've had my spouse now suddenly does nothing but online shopping and is financially bankrupting us he just will only eat powdered donuts every day. Because he just likes them. And so when you see them in the clinic, you can tell something's not right. And it's not a cognitive thing. It literally is their mood. And then, also what you can comment, and you have to be on the lookout for this, depression is something that you always should be on the lookout for with your patients with metastatic lung, particularly when they have brain mets, but especially if they're on lorlatinib. There have been a few case reports of suicides out of the blue, completely unexpected, when patients do get that severely depressed and they're on a drug like lorlatinib.
Of course, on the other side, it looks indirectly like really effective, and maybe that's even correlated with it, Stephen?
Yeah, I think that if you're looking at best drug in terms of long-term benefit, it is the winner. Objectively, it has the longest progression-free survival. It clearly is, we think, a little bit more effective, but it comes at a cost. And these side effects, this is sort of where the calculus gets a little bit tricky. This is a point where it's really important to make sure that family are engaged and really all members of the medical team, where if someone's not acting right, because a lot of times there's no insight into it, where the patients they're not aware that their personality has changed. And so we rely on family, on children, on caregivers, on friends, on other medical staff. Sometimes the MAAs will tell us really not acting right. And if we can catch it, they can respond to dose reduction. So if you lower the doses, a lot of times we can still get that benefit without those side effects.
So faculty, audience, you've been told that your next patient you're going to see in clinic is a 24-year-old medical student with metastatic lung cancer. Tara, can you tell us the story?
Yeah. So I'll start by saying I think this patient is probably the highlight of my whole career. Just one of the most interesting situations and people that I've ever met. So he was 24 when he first came to us, non-smoker, finishing up med school, and here he had metastatic non-small cell lung cancer. So the day that he was to start chemo, the physician asked me if I could go down and meet with him, talk to him, get to know him. And when I walked into the room, he was leaning forward. He was kind of pursed lip breathing. His face looked a bluish gray. And I was like, we're in trouble. So I called him and I said, we got to get this kid to the emergency room really quick. And by a few hours later, he was in the ICU. He had a cardiac tamponade. He wound up going into SVT and his heart stopped. So he had an emergency, pericardial. Thank you.
They stuck a needle in his pericardium.
Thank you. They stuck on his pericardium. And then he wound up getting chest tubes in both of his lungs as well. So he was very, very, very sick. And in a panic effort, he got a dose of cisplatin pemetrexed in the ICU. And the next day, the medical oncology walked into his room and said, "You're never going to believe this, but you have an ALK mutation." And as crazy things have it, crizotinib had just gotten FDA approved 1 or 2 days before that. So he started crizotinib, and he walked out of the hospital somewhere between 2 and 3 weeks after that, just as normal as could be. He had an amazing, miraculous response to it. It did not last for a long time. He was on crizotinib for 6 months, and he did progress. He went on to receive quite a combination of chemo, bevacizumab. He was on pemetrexed for a while. He went to Colorado for a second-generation ALK drug that didn't work out too well. Then he came back to pemetrexed with crizotinib together. And then ultimately he went, I believe it was Michigan, when the lorlatinib became a phase 1 clinical trial. And he had a really great response to lorlatinib, and he's been on it for 8 years. So he's been our patient for, it's going to be 12 years at the end of the summer. And he went on to get married to his college sweetheart, and they are expecting their first child. So it was a great story to be a part of. And outside of just the clinical part and the emotional part of it, he's really a great person who went on to, he obviously didn't do a residency, so he went on and got his PhD, and he even came to the clinic and he did lung cancer research for a few years, and now he works with a company to try to help get clinical trials set up so that more patients have access to clinical trials.
So, I know how often people say, isn't oncology depressing to be in? And it is a tough field, there's no doubt about it. But I think experiences like this are ones that most people in this world do not have. Can you just share, you were telling me about that his mom throws these big parties for him at 5 years and at 10 years.
Yes.
Can you maybe just comment on that?
Yeah, so his mom was a fierce advocate from the very beginning. I mean, when he was sick in the ICU, she fought really hard. She helped us actually with working between the pharmaceutical company, and I mean, we had to get crizotinib flown in. We didn't even have it at the clinic yet, when we found out he had the mutation. So it was a lot of work getting him the drug so quickly. And she was there advocating for him every step of the way. So when he hit his 5-year mark, she threw a gigantic party for him downtown Cleveland, and it was really, really cool that the ICU physician that drained his pericardium his medical oncologist, his radiation oncologist, all the nurses, all of us were there. And then he had a 10-year party 5 years later. So I'm waiting for his 15-year party. That's what I'm waiting for.
What about the part where you all did shots at the 5-year thing? No,
And
we
that
won't get into
happened. Yep, I will say the oncologists and all of us were lined up right along with his mother, and we did tequila and celebrated a lot that night.
All right, so back to targeted therapy. And Anne, this is a kind of a diagram showing the frequency of various types of mutations. And you see up there in blue, EGFR sensitizing mutations. We're about to hear a case from Jillian of a patient with an EGFR mutation who actually got adjuvant therapy. So now, for the first time, we're seeing not only in metastatic disease where we see these drugs being very effective, but like you always see in oncology, moving into the adjuvant setting. There is a study, that so-called ADORA trial. Initially, it showed a dramatic drop in the recurrence rate, but people were kind of worried, okay, well, maybe it's not going to really make a difference in the long run because you can wait until they get metastatic disease and treat them then. Maybe it's better to do that. So what people have been looking for is there going to be a survival benefit? So we saw a dramatic drop in recurrence. Actually, the risk of brain mets went from 10% down to 1%. But still, they didn't see a survival benefit, and they don't want to see that in order to get to use a drug, and they feel comfortable about it. Well, in a few weeks, we're about to see the survival data. It's going to be one of the so-called plenary presentations. They pick 4 or 5 of the top papers in the entire oncology spectrum. This is one that's going to be presented because it's so important, affects so many people. And undoubtedly, we're going to see other adjuvant situations. This man, 74-year-old man, Jillian took care of. First of all, Anne, can you sort of separate out what stage 2A means in terms of risk of prognosis with chemotherapy, for example, or out? And also, what is an EGFR L858R mutation?
Mm-hmm. So in non-small cell lung cancer, obviously stage 4 we don't consider curable yet. Or that we would give multimodality therapy. But usually for stages 1 to 3, we are always considering multimodality treatment. For stage 1, we're usually going to do either radiation or surgery. For stages 2 and 3, that's where we have to tailor our treatment to the patients. So in this case, this was a patient with stage 2A. So they probably honestly have about a 70-75% chance at 5-year overall survival with just chemo and surgery. And so the goal, of course, now, and we're going to hear the survival results, is if they have a genetic oncogenic driver mutation, can we do better with the addition of adding that targeted therapy, in this case the osimertinib, which targets this specific EGFR gene mutation. And L858R EGFR mutation is considered a very sensitive mutation, meaning that the tumor cells are highly sensitive to that targeted drug osimertinib. And so it should work very well for this patient. Now, the trial that is being presented gives the targeted therapy, so you got to take a pill for up to 3 years, which can be tough. But in essence, after surgery, you can get adjuvant chemo in stages 2 or 3, and then you can get the adjuvant osimertinib as treatment after that. And then we'll hear about the OS survival results.
And we've talked about patient involvement, and up until now, when we talk to patients about getting adjuvant targeted therapy in this situation, we have to say, look, we don't really know whether you're going to live longer, but you will have a lower recurrence rate. For you, is it worth going through 3 years of taking this pill, and maybe in the long run it won't change when you die, but you'll have lower risk of recurrence? A lot of people chose over the last few years to do it. I've heard plenty of cases where people chose not to do it. Now we're going to have new data showing it really does make a difference, and maybe some of those people are going to come over. I'm curious, this man got treated, in the earlier part. We didn't have the data we're about to see. Can you talk a little bit about him and how he presented to you?
This was a patient who had resection and then received chemotherapy after the resection and then got the osimertinib. and did really well. I think what's unique about this patient, and I think what you're talking about, getting the data, this patient was on the osimertinib for almost 2 years. And the unique case is, which I think is something that we have to consider as providers, is that we're prescribing these medications based on what we think is best for them, but there's other factors that are involved in that, like coverage, copay. Can it be afforded, or, is it an affordable therapy for those patients? And it's something that I don't think as providers we get very involved in. And in this case with this patient, you're looking at, are they compliant? Are they taking the right dose? Are they taking it daily? We want to make sure of that, and we check that when we're seeing them regularly. But in this case, this patient had a transition of life from working to retirement, and the coverage was no longer affordable. So as providers having to make that decision, trying to get assistance from the pharma and not being able to because of income. So making that decision that we couldn't continue to treat with the osimertinib, not because it wasn't effective, but because it wasn't affordable anymore. And I think that's something that we have to be mindful of and really check in with our patients, because it's not only like, if you're compliant, are you compliant? Or if you're not compliant, are you not compliant because you can't afford the medications? I think we've all heard of patients that try to stretch out their drugs, and then we can find that it's not as effective. Fortunately, this patient was able to get a significant length of treatment that we hope is going to keep things quiet, and we'll continue to monitor closely and can, if we need to, go back to something else. But it's something to consider, the full picture when we're treating our patients.
That's such an important point. Again, we were talking about this yesterday in the CLL section, where, we have these new novel agents. They're oral, which is great. But again, you have different insurance coverage. You have copays with orals that you don't often have with IV. When you do surveys of CLL, there are a lot of people they're not getting these drugs because they can't access it financially. What about this? So you said did he have any tolerability problems, any side effects for the drug?
He tolerated, very mild symptoms, so he tolerated it very well. It wasn't something that we would have continued because he was able to maintain life very well. So there wasn't any toxicity limitations to the treatment. So that's kind of a sticky spot to be in.
So Tara, I'm curious, we use osimertinib, and before that there were other drugs that actually had a lot worse tolerability. I don't know if you've ever heard of erlotinib. That was another one, even gefitinib before. These newer agents seem to be more effective, maybe less toxic. But right now, Tara, if you have somebody who's going to receive osimertinib, of course, if they're going to get it in the adjuvant setting, they need to understand, what the purpose of it is as opposed to metastatic. But what are some of the sort of common side effects and toxicities or even serious problems that you can encounter that you bring up to patients about to begin osimertinib?
So the most common things that we see are skin rashes, typically like an acne-type rash, and then also diarrhea. Those are the more, dry skin or mucosal irritation. Those are the more common things that we see. Sometimes, some irritation or infections around the nail beds. Most of those things are really pretty treatable and pretty tolerable. The one thing that we do, try to educate patients about is the possibility of, like an ILD. So if patients develop any kind of shortness of breath, anything that they're worried about that feels largely different than their baseline, we do encourage them to call us right away, because that would be one of the more serious side effects that we'd want to monitor for.
So another issue, and particularly in the metastatic setting that we I don't think, talked about, Anne, is the issue of people with metastatic disease who have targetable lesions. They get targeted therapy, and most of these patients eventually will progress. Sometimes, although here you have your patient 9 years, but more typically they will progress at some point in time. And then you're looking at other modalities, chemotherapy, clinical trials, et cetera. But it also gets into whether or not how checkpoint inhibitors work in these patients. Because first it was observed with the EGFR patients and ALK patients, and now we're seeing it with these others, that it doesn't look like checkpoint inhibitors work very well and maybe aren't even maybe worth using. Can you talk a little bit about why that is and in what situations you actually use a checkpoint inhibitor?
So the thought is that when you have your immune system totally revved up, it's going to basically go after DNA that doesn't look like yours, right? So things that have a lot of different mutations. So most, lung cancer smokers, they have lots of genetic alterations in their tumor. That's why, believe it or not, the former smokers, current smokers have the best responses to these immunotherapies. Now, if you have a never smoker, they generally are ones that carry one of these oncogenic driver alterations, and they generally don't have other mutations. And so immunotherapies, we have found, do not work very well in these patients. So I can't say that that's the case for every single one of these oncogenic mutations. For instance, Stephen brought up the KRAS mutation. That's generally found in smokers, and that generally does have other alterations. So there's something called STK11 and KRAS. When you have those two, you don't respond very well to immunotherapy, but the other combinations generally do. And so we don't know yet for every single alteration, but I will say this, I almost never give an immunotherapy to my ALK rearranged patients because they don't respond well. And why give somebody ineffective treatment and then mess them up potentially for a targeted therapy later? And I also save immunotherapy to the very, very, very end for my patients who have EGFR mutations, because there are so many new drugs being developed right now for all of these mutations, and many of them will pose the same risk when you interact with immunotherapy and these new 5th, 6th generation EGFR altered drugs or TKI drugs.
In the metastatic setting, Stephen, another issue is whether or not you can use a second form of targeted therapy after the first. So again, all these things, a lot of these things started out with EGFR. That was really the first mutation that was discovered, and then these others came along afterwards. So we have a lot more data there. But in terms of the use of IOs, I'm curious, Stephen, how you approach this in patients with targetable lesions, and also the issue of looking for resistance mutations. Mm-hmm. So typically, if you give a patient osimertinib, for example, for metastatic disease, they almost always will respond, but at some point, maybe a year or two later, they're going to progress. It's not a permanent thing. What about at that point, rather than going to chemotherapy, looking for new mutations that can be resistance mutations? You could use a second form of targeted therapy. How's that working out, Stephen?
Yeah, it's something we try to do. If we start a targeted drug and it works like we expect it to, patients feel really well, the cancer gets smaller. If we're still taking the same medicine and one day the cancer starts growing, if we didn't change our treatment, that means the cancer changed in some way. If we can try to isolate exactly what changed, sometimes we can adapt our therapy. And so if we find mutation number 2, maybe it's a combination of drugs. If we find a new mutation that sort of prevents one drug from working, maybe there's another one out there that'll work instead. So we try to make as rational a decision as we can. This is a space where trials work really well. Trials are different than they were in the 70s and 80s, where we were just using animal and plant extracts that we find and seeing if they did anything. Here for targeted therapy, we know the exact mutation we're looking at. Chemists go in, they design a drug. It's medicinal chemistry, and so even if it's a first-in-human phase 1 study, this might be the best option for a specific patient. So we really try to get targeted therapy combinations based on what's happening with the cancer today, and for that we need biopsies. That could be a liquid biopsy, which is a blood test, takes about a week, or a tissue biopsy, which sometimes is a little harder to do. That takes a couple weeks to get those results back. I agree with Ann, immunotherapy can work for some mutations, but we tend to reserve that for later down the line. And if we're thinking immunotherapy for EGFR, ideally not a drug that's already been out there, hopefully something new. And that's, even if you're thinking immunotherapy, you really want to be on an immunotherapy trial, not the old stuff. So
Ann, Stephen referred to so-called liquid biopsies, which really, lung cancer, I think, really innovated. Now you're seeing liquid biopsies used throughout oncology. What exactly is a liquid biopsy, and how reliable is it compared to tissue?
So for instance, so you have to picture tumors. They undergo, there's lots of different cells in there, and they all undergo the cell cycle, and you end up with some cell breakage. When the cells die and break open, you sort of release DNA into the bloodstream. Now, that doesn't go become new cancer. It actually is a waste product. But what we can do now, using this technology, is we can take some blood from the patients, and then we, just like in, those detective shows, you can actually PCR up the DNA. You can detect normal DNA, and you detect tumor DNA, and sometimes you can find the genetic mutations in the tumor DNA. So this is obviously faster and easier to do than biopsying your patients. You don't have to set them up with another pulmonologist or interventional radiologist and then wait for that appointment and then get them cleared for the procedure and then the biopsy. So timing is everything here. Now here's the problem. Not all tumors shed. We call it shedding for the DNA. So for instance, if you've got a pretty quiescent tumor and you don't shed, you don't necessarily pick up anything in the blood. So that's the one problem there. Now, if you are strapped for time, what I usually will do is I will send the plasma and I will try to see if I get a mutation. If it's positive in the blood, it is positive. And you could cancel the biopsy, because routinely I'll get the blood test back before I get even the biopsy results back, or the biopsy tissue done. Usually, when you see this, you can go ahead and treat, and most insurance companies will enable you to use that data to justify the treatment for the targeted therapy.
So one more question before we get to another case, Stephen. Anna was talking about mutations and the number of mutations being correlated with benefit from immunotherapy. There are assays being done. There's one called tumor mutation burden, where they try to sort of add up the number of mutations. There's actually an approval of any cancer who has a TMB that's high to use an IO, pembrolizumab. What about that and other predictors? We were talking about the fact that a lot of these patients don't respond. Even people without mutations, a lot of them don't respond. What about TMB? Ann mentioned the other markers to try to figure out who's going to benefit.
Predictors for immunotherapy are still pretty rudimentary. We use expression of this PD-L1 protein. Looking at the number of mutations, that does seem to increase the likelihood of response, but didn't do such a great job predicting who was going to live longer. Right now, we don't really use that in lung cancer. You're right. There is an immunotherapy drug, pembrolizumab, approved as a second-line treatment, but we've already got immunotherapy approved as a first-line treatment, so it never really comes to that. Over the next few years, that's where we're working. We're refining to get a little more sophisticated and really being able to tell from the beginning, is this person in front of me likely to respond to immunotherapy or not? A lot of it based on work that Ann and her colleagues are doing right now.
So before we hear about this case, Ann, maybe you can talk a little bit about the spectrum of EGFR mutations. You mentioned that this mutation that this other patient had was an activating mutation, so where you typically see responses. But you see a whole spectrum of EGFR mutations, and one in particular that didn't seem initially to respond to drugs like osimertinib, this patient had, which is an Exon 20 insertion. Can you explain what that is and globally how that differs from these activating mutations?
So EGFR mutations are not the same. So these are just different DNA abnormalities within the same gene, and the EGFR gene. So there are two common sensitizing mutations. The one you saw before, the L858R, and then there's one called a deletion exon 19. Those are the most common EGFR mutations you'll see. Most of the drugs that we have will target those two alterations. Now, we've discovered that there's probably 1% to 2% of our lung cancer patients that carry these other EGFR more rare mutations. A G719 is one example. In this case, we also have exon 20 of the EGFR gene. Now, the reason why this is so important is we have drugs that can target this alteration, and they can be effective. So, for instance, afatinib, amivantamab, which is actually the way you can tell if it's a small molecule inhibitor is the last of the generic name. The last three letters are NIB. That usually means it's a small molecule inhibitor. If it's MAB, that stands for monoclonal antibody. So these are just different classes of drugs that target the same thing.
So can you talk a little bit more about what amivantamab actually is, Ann?
Yeah, so amivantamab is a monoclonal antibody. And it, of course, one of the way antibodies work is you have to have a target. And so this drug actually targets specifically the EGFR exon 20 alteration. Now, the side effects to this are very different, and the delivery systems are very different. Before, when we're talking about the NIB, the small molecule inhibitors, they're all pills. For monoclonal antibodies, you still have to go in and get an IV infusion. And because antibodies are a little tricky, the schedule for the amivantamab is very tricky. You have to go in for loading dosing. You have to, for the first 8 weeks, you're pretty much in every week. And then you can do a little less frequency. But this is, new. It's first in class for the EGFR targeted area. And so I do think we can develop better, and there are additional drugs coming that I think will build off of what amivantamab has done.
So again, before we hear more about this case, maybe you can elaborate a little bit more about this drug, Stephen, because it's not just a regular antibody, it's a bispecific. And we've been talking about that all week in hematologic cancers. There's one approved in myeloma, another in follicular. We had a great analogy in our lymphoma session the other day. They were talking about Lady and the Tramp and how they were eating the spaghetti, and the spaghetti brought them. That was the way he explained what a bispecific is. But this is not an immune bispecific. It's a very unique type of bispecific. Can you talk a little bit more about how they sort of constructed it and how it works?
Yeah, so amivantamab, these are all engineered molecules, and so a chemist gets in the lab. Antibodies are kind of like a Y. We've got these two arms that are binding to different antigens, and in our body, they'll both bind to the same thing, different protein on the bacteria, and it just lets us cluster them together so our immune system can clean them out. Amivantamab is constructed in a way where one arm binds to EGFR protein, the other binds to MET, the protein. And those are commonly expressed in certain cancers, and that's why this drug can sort of target those for destruction. Now, in EGFR exon 20 lung cancer, is it mostly binding to EGFR? Is it also binding to MET? Is it binding to both? We don't really know. Probably binds to a little bit of all those combinations, but has the ability to bind to all of them. That's why it's being studied in, it's approved for EGFR exon 20, but it's being studied in other EGFR mutations. It's being studied in MET exon 14 mutations, and we'll probably find a role in a lot of different places as well.
And we were talking about people who have progressed on osimertinib. This has been looked at in those patients as well, combined with a drug like osimertinib. What happened with this 73-year-old man, Jillian?
So this metastatic non-small cell lung cancer patient had CNS involvement. He had a lingualectomy. He later had some progression. He did chemotherapy. He has this EGFR exon 20 mutation and is on amivantamab. And tolerated pretty well, responded. The side effects he experienced, he had some lower extremity edema, not gross edema, but had some skin effects, really dry, cracking heels, and a rash that kind of flared after the infusion. But a lot of that has been well managed and improved, and he's tolerating. Now, during this course of treatment for the lung cancer, he also developed prostate cancer that was able to be managed with radiation only. So he's doing pretty well. We are monitoring. There is a pancreatic lesion that just was slowly growing. We still not sure that it's malignant.
And here you can see the diagram of this bispecific antibody that we've been talking about. But Anne, we also have another agent that's been used in the same exact situation, very different, mobocertinib. And a lot of patients end up getting both of these. If this man has disease progression, and perhaps he's going to be offered mobocertinib. What is it, and how would you compare it to amivantamab in terms of efficacy as well as side effects?
Yes, so mobocertinib is, again, a small molecule inhibitor. It's a pill, and you take it once a day. Now, the side effect profiles, I'll be honest, are not that different. It's really, rash. It's the typical things you experience with the EGFR inhibitors. Rash, diarrhea, fatigue. You have to watch the liver enzymes. So in terms of side effect profiles, it's not all that significantly different, but it's more convenient. It's a pill. It's more difficult to dose reduce though, because of the way the pills are constructed. But it's certainly something that is an option for these patients who have the exon 20 alteration.
So Tara, I'm kind of curious what your experience is with these two drugs, mobocertinib, if you've actually used them, and amivantamab, and what are some of the things that you bring up to patients who are about to begin these drugs?
So I haven't used mobocertinib. We do use amivantamab a decent amount. I do try to prepare them, just mostly about the skin rash, because it can be really pretty bothersome. I have some patients that have done well with minimal toxicity, but I have a couple people that have had really extensive, scabbing and dryness of the scalp and the face, and it can be difficult, to accept, to want to go out like that. So I try to educate them on good skincare to start with, and then if they develop these symptoms, to let us know right away, because I think the sooner that you start, more aggressive management of the skin stuff, I think it goes better. With the amivantamab, there's also the possibility of having infusion reactions, so I discussed that with them as well. It doesn't seem to be an issue. We pre-medicate, and even with some reactions, we've been able to manage them fairly easily.
Stephen, how do you decide which one you're going to use first?
There are different modalities. Like Ann said, the schedule for amivantamab often dictates which one you're going to choose. For amivantamab, it's given weekly for a month and then every 2 weeks, kind of indefinitely. So if you're driving in 3 hours to see me, it might not be conducive to sort of keeping a full-time job, for example. Mobocertinib is oral daily, but there are different side effects. And amivantamab, for us, the infusion reaction is pretty common, but they're different from like a paclitaxel infusion where maybe you wouldn't revisit it, or a carbo infusion where it's really anaphylactic. That's not what this is. Really, this happens with the very first dose you get. And so cycle 1, day 1, you're going to get an infusion reaction. The majority of people do. You stop, you can re-challenge, but in our center, just throw it away. It's so common that they actually split the first dose into day 1, day 2. So day 1, you get a reaction, just throw it away. It's fine. Come back day 2, it's never going to happen again. Weekly, it's not going to happen. Every 2 weeks, it's gone. It's just that first time. Now, if someone takes 2 months off and then comes back again, well, then you're probably going to get the infusion reaction again. You're sort of starting all over again. But it doesn't mean that, it's very different from an allergic reaction. It's generally pretty safe.
How do you compare the types of responses you see, Stephen, compared to, say, what you see with ALK and EGFR agents?
These are first-generation drugs. These are approved drugs. They work, but the response rate for these drugs is around 30-40% tops. So this is not going to be like an 80-90% like ALK and RET or osimertinib with EGFR sensitizing. These are early-generation drugs. We're glad to have them, but they're not going to get a significant response in the majority. That's why, for now, these are approved as second-line treatment, not first-line treatment.
So normally you're looking for a drug that causes the response rate 50-60% to use it in first line?
You'd like to have some confidence where someone sitting in front of me, I tell them, we give this drug, it's probably going to shrink the cancer. You can't really say that with these drugs. There is quite a bit of stability. They're good drugs, but these are early days. Hopefully, next year we'll talk about better drugs.
When you do use first-line therapy, do you use immunotherapy? We were talking about the fact that some of these targetable lesions, the feeling is they don't respond. But what about this? Do you use immunotherapy?
I don't, because as Ann said, this can complicate subsequent targeted therapies. And if we look at the basic immunotherapy trials that are out there, they actually excluded patients with EGFR mutations, including these ones. So for the most part, the immunotherapy data don't apply here. I think there's not a lot of benefit. And in fact, at ASCO, we'll see the results from Keynote 789, like chemo versus chemo plus Pembro, showed no difference in the frontline setting for EGFR.
Interesting. Okay, Tara, you have a patient with a RET fusion. These are alterations that you see really good responses, more along the lines, I think, of what you see with EGFR agents. What happened with this 60-year-old lady? Was she a smoker, incidentally?
No, she was not a smoker. So at the time that we met her, she was 47, so we've been treating her for 13 years now. She is a nurse practitioner. She's married. At the time, she had 2 school-age children. And initially, she was treated with Taxol, Carbo, bevacizumab. And she had a really very good response to that. She even went on to get concurrent chemorads for an area of progression. And then she went on to pemetrexed, and then she got nivolumab after that. And when they found the RET fusion, she was started on selpercatinib on trial.
And how long ago was that she got started on selpercatinib?
6 years.
So she's had metastatic disease for 13 years?
13 years.
Wow.
Yep.
So what happened?
So she's been on selpercatinib for the last 6. Initially, she was dose reduced relatively quickly for some diarrhea, and then she really was tolerating things overall really pretty well, except that she started developing this fluid retention syndrome. So she started getting ascites, and she had pleural effusions bilaterally, a little bit of swelling in her lower extremities, and we wound up having to start tapping her. So she was, getting paracentesis. She wound up having, water drained off both of the pleural effusions, and eventually, after she'd been tapped a number of times, we decided to dose reduce her again to see if that would help. And since she's been dose reduced a second time, she has stopped having this, fluid reaccumulation. She's tolerating it well. She's still responding.
So, Anne, we're not trying to say this is a typical case of somebody who can stay on a RET drug for 5 years, but you kind of provide an overview of what we know about RET, what agents we have to treat it, and what's a more typical response that you'll see?
Yeah, so typically for selpercatinib, we're looking at if they are treatment naive, their response rates are quite high in the 70+%. And the median duration response, well over like 20 months for treatment naive. Now, it always, for pre-treated patients, which is what this patient falls into, the response rates drop down to like 50+, 55%, 58%. And the duration response usually drops down to about 11 months, less than a year. So this is quite a remarkable patient. Her side effect also was a bit unusual, though. We don't typically see such anosarca. We're mostly looking for like hypertension, myalgias. We want to look out for QTc prolongation, ILD, the usuals. You can get a little bit of bleeding with this class of drug too, so you have to watch out for those things. There are currently 2 FDA agents, the pralsetinib along with the selpercatinib. Selpercatinib's been out there longer, so that's usually, just out of habit, that's usually what I go to.
Any way indirectly to compare them? And to me, it looks very similar.
They're probably similar. They both have CNS penetrance. We probably need a little bit longer to figure out whether or not there's a particular RET fusion that might respond better to one or the other. But there are a lot of third-generation RET inhibitor drugs coming down the pipeline now, though.
So, Tara, I'm curious what it's been like to treat her, a nurse practitioner who's had this amazing response. What's it been like?
Well, I always think that, treating a nurse, a physician, advanced practice, I always feel like that hits a little closer to home for me. And I feel like, I think the reason that it gets to me so much is that all of us, we spend so much of our lives taking care of other people. So when, one of our colleagues, is diagnosed with something that's really difficult, I feel for them, and I feel like it's an honor to help care for them.
So we talked about the CNS penetrance of these drugs. Stephen, what do you do when a patient like this shows up with a brain met? We were talking about this before. Do you usually, how do you decide whether you're going to treat locally, try to take it out surgically, use radiation therapy, or maybe just use targeted treatment?
So generally for RET, we're thinking targeted treatment. These drugs work so well in the brain, they work so quickly that I can generally get a response before the radiation oncologist can even sort of get started. Exceptions would be if someone presents up front with symptomatic brain metastases. Sometimes those patients will actually go straight to surgery before we even know it's lung cancer, and certainly before we know a RET fusion's there. But for RET, for ALK, for EGFR, drugs work really well. If we start a treatment, certainly depending on the location of the brain lesions and the severity, if we follow closely, we're pretty comfortable with that. Whereas if we look at our MET inhibitors, if we look at our BRAF inhibitors, those aren't quite as good in the brain, and there I probably have a little bit more tendency to call in radiation early.
So we're not going to talk very much about BRAF, Ann, but we have been talking this week about the idea, and I mentioned we had this symposium last night on HER2 across tumor lines. And more we're seeing this idea of looking at a biomarker. Another one we've talked about is MSI high, where they respond to immunotherapy. We talked about that in our endometrial cancer program. Also in colon cancer, you see this in terms of really focusing on what the marker is rather than where the tumor is. Where do you see that heading in the future, Ann? Do you see that in the future we're going to be focused more on the biology of the cancer rather than where it started?
You know, I don't think so. I think it's always going to matter. And the reason I say that is a KRAS colorectal cancer behaves differently than a KRAS non-small cell. Just as a BRAF V600E melanoma behaves differently than a BRAF V600E non-small cell. Like our BRAFs can be incredibly indolent for non-small cell, whereas that's not the case actually in melanoma, and sometimes you find germline mutations in melanoma.
What do you see, Stephen, with BRAF therapy, the typical, and the regimen's been approved as dabrafenib, trametinib with a MET inhibitor. Again, that started with melanoma. What about when you have patients with BRAF, patients with lung cancer? Do you use targeted therapy up front? Do you use it second line? How does it work in the brain? All these questions, IOs. What's your profile for BRAF, Stephen?
This one's a little trickier. So BRAF mutations come in a lot of flavors. V600E would be the one that we can target in non-small cell lung cancer. And in that one, dabrafenib, trametinib is approved. I tend to use that first. There are other BRAF mutations. Half of them are non-V600E. Those don't respond as well to dabrafenib and trametinib. So in that setting, these often are mutations that will respond to immunotherapy. So immunotherapy is, I think, on the table for BRAF. Big question, we know in melanoma, the BRAF positive melanomas, immunotherapy is better if you use it before the targeted drug. And we saw a survival benefit in the melanoma setting. We don't know if that's true in lung cancer, but because of reasons we talked about before, we tend to favor targeted therapy first. So right now I still do targeted therapy first, but if they do progress, I think immunotherapy is very much on the table.
Jillian, any experience using BRAF therapy, dabrafenib, trametinib? In melanoma, we heard about fevers that you can see with these patients. Do you see that in lung cancer?
I've had a few patients, and so I've seen fever. I've also kind of looked into kind of how other disease processes, so I don't have as much experience with the lung cancer population. I'm vaguely recalling a patient from a while ago, so I was trying to think their side effects. It was a fairly older gentleman. I think with him primarily, I think he had a lot of myalgias, arthralgias.
And what have you seen? Have you seen fevers? Because I heard that from the melanoma people, but do you see that in lung cancer also?
Oh, all the time. That's actually usually why we have to dose reduce them or withhold, at times their treatment.
So let's talk about another case. This is a patient with another mutation. Actually, we've been wanting to target KRAS for a long time because it's really one of the most common alterations you see, but we haven't been able to find anything that works. Now we're starting to see a couple of drugs come along, Stephen, with one of the variations, KRAS G12C. We're going to talk about this patient, a 58-year-old woman of Tara. But can you kind of provide a little bit of background about what KRAS is, Stephen?
Yeah.
What KRAS G12C is, and what kind of effect we see with targeted therapy?
KRAS was one of the first oncogenes we discovered, Kirsten-Rat sarcoma virus. An oncogene means that if you turn that one on, it can lead to a cancer. That can be enough to cause a cancer. And these are pretty common in lung cancer. They're not the same proteins that we see like EGFR and ALK, where you have an overactive protein. These are not transmembrane kinases, and so they live inside the cell, and they are sort of in the center of a very complex signaling pathway. So it's been very hard to block these because there's a lot of redundant pathways. There are many different types of KRAS mutations. They're all a little different. You see these letters and numbers, these sort of license plate things, that it's all biochemistry from college, right? So G is glycine, C is cysteine, so it means that codon 12, the amino acid changes from G to C. And that one change is enough to sort of lead that KRAS to be overactive. And then our inhibitors, the new drugs we have, they bind to that C, and so it's really important that when we think of KRAS and lung cancer, it's not positive or negative. We need the details here. KRAS G12C is different from KRAS G12V, and the G12C inhibitors, they need that C to work, so they'll work really well. If you give the same drugs to a G12D, it's not like they'll work a little bit, they won't work at all, because they really need that C to bind.
So we're just in the beginning of trying to attack this target, and we have two agents that seem to have some activity. Again, it doesn't look like what we see with EGFR and ALK, but at least we're seeing some responses. We have this drug, sotorasib, and another agent, adagrasib, which is actually what this patient got. Can you talk about how these agents work and what you see in terms of efficacy and tolerability, Anne?
Yeah, the sotorasib has been the one that's first on the market, and adagrasib came later. And they're approved for after frontline chemotherapy progression. But what I will say is lower your expectations for this right now. These are not like the EGFR ALK drugs where you just see, the Lazarus effect where the tumors just completely melt away. These tumors can give you a response, but it's not going to be like that. And the duration of response is far less in terms of, we're looking more along the lines of 6 months, So again, we're just at the beginning of understanding KRAS and having these targeted agents. There are probably, I'd say, 6 or 7, Stephen, additional pipeline KRAS altered drugs that are going to be coming to the market. And I am hoping and praying that those are way more effective than what we have right now. But these are 2 agents that are FDA approved. They can be used in the second line or third line after prior chemotherapy with or without immunotherapy in these patients.
All right, let's hear about your 58-year-old woman, Tara. What happened with her?
So this lady was a 58-year-old smoker with metastatic non-small cell. So initially she had carboplatin, pemetrexed, and pembrolizumab, which she had. She did have a response to that. She did go on to receive radiation to the lung, the brain, and the bone, and then went on second line adagrasib on a phase 1 clinical trial. And she tolerated it okay. She had some kind of general typical side effects where she just had kind of low energy, maybe low appetite, a little bit of some GI side effects. But she went on to have repeated hospitalizations for things that we weren't really sure were related, non-related. She was getting UTIs, she had some confusion, she wound up getting pericarditis, needed to have a window. And eventually, she was only on the adagrasib for about 6 months, and she progressed. So initial response, but quickly progressed, and has since passed.
Any comments about what it was like to take care of her? It sounds kind of frustrating.
I would say that she does fall into the category of those patients, that it is a little frustrating that there's some people that you feel like you never gain any ground with the cancer. So these cancer symptoms have never really improved from the beginning. And then you're starting to develop some of the side effects from the treatments, and you've got this kind of bad mix of both of those, and you never really get to a place where you feel like you've achieved a lot.
When you look back at her, the care you delivered to her, do you feel a sense of satisfaction that you provide of the care that you provided to her? Do you think that the relationship you had with her was of value to her?
I'm not sure. I think that we did the best we could. I think that she had some disappointment that she didn't, improve. But I do think that she appreciated, what we did for her, and it's just the outcomes are not the same for everybody.
Some of the most important things that are happening in this meeting is on people's faces, just their expression, and that's another message through here. One other form of targeted therapy I just wanted to bring up as sort of a bonus. We did talk about this a little bit last night, but I'm curious because it really is a completely different issue in lung cancer, which is the HER2 positive disease, Stephen. And we know, of course, in breast cancer, anti-HER therapy has been a very important part of treatment, but now we're starting to see anti-HER therapy coming into other cancers. We're seeing it in colorectal cancer, trastuzumab, tucatinib, the TKI, now approved in metastatic HER2-positive colorectal cancer and upper GI cancers. And lo and behold, we see HER2-positive lung cancer, but interestingly, where in these other cancers it's usually overexpressed, in lung cancer you have HER2 mutations. And of course, we're talking also about the antibody-drug conjugate trastuzumab deruxtecan, which has been used in breast cancer for overexpressing HER2, but seems to also be active when there are HER2 mutations. Can you talk a little bit about what you see in terms of HER2-positive disease in lung cancer and where TDXD is starting to come in, Stephen?
Yeah, so it's a good point. HER2 in lung cancer is not protein, it's not amplification, it's mutation. So they're generally an exon 20, but HER2 mutant lung cancer, a couple percent of lung cancer will have this mutation, and when it's present, an antibody-drug conjugate is now FDA approved as of last year. So trastuzumab deruxtecan is an antibody-drug conjugate. It has an antibody that binds to HER2. It has a linker that then connects to a payload, and the payload is kind of like a chemotherapy, but it's given as a prodrug, an inactive drug. So we give it through an IV, it circulates in the body. When it binds onto the cancer cell that's expressing HER2, it gets sucked into the cancer cell. Once it's inside, the pH is different on the inside, the conditions are different, and so that linker kind of breaks apart. When it breaks apart, you release that chemotherapy. That chemotherapy is now active, it kills that cell from the inside, and then now it's floating around in the body and it kills all the cancer cells nearby. We call that a bystander effect. And it's very effective. Chance of response is over 50%. It can be very durable, but the side effects are different. When we think of EGFR and ALK inhibitors, other targeted therapies, generally pretty mild side effects, generally not observable. For antibody-drug conjugates, if it's conjugated to something like chemotherapy, the side effects are like chemotherapy. So myelosuppression, neutropenic fevers, alopecia. So you see nausea side effects that align much more with chemo.
And it's interesting because you don't see HER2 mutations that often in breast cancers. There really wasn't that much data, but it's more common to see mutations than overexpression in lung cancer. What do you see in terms of efficacy? Is it effective enough that you want to, it's approved second line, do you use it first line?
Well, between you and me, if no one else is
Don't
listening,
tell anybody.
just between the two of us, yeah, I use it first line. That's my drug of choice. And so it hits all the check marks for me. High response rate, I think better tolerated than chemotherapy, more durable than chemotherapy. So that is what they use in the frontline setting, though it's not FDA approved.
Although, and there is another caveat to this drug, and of course this has really been a huge issue in breast cancer, which it can cause interstitial lung disease. Mm-hmm. And we've heard this over and over. So many drugs in oncology, chemotherapy can cause interstitial lung disease, but they've had fatal cases of interstitial lung disease. It really gets your attention when you're using a new drug. And in particular, breast cancer patients in general have normal lungs, GI cancer patients normally normal lungs, lung cancer patients, different story, a lot of smokers, chronic lung disease. How does that factor in when you think about this drug, Ann?
Yeah, well, it was a tough one. When we saw the trial came out and we saw the deaths, I think there were 2, everybody cringed. Because this is the last thing that you ever want to do is do harm. But I will tell you that lung cancer is pretty bad for patients too. So it's all about a risk benefit. It's about educating the patients. We do know how to treat ILD. And so if the patients are communicating with the physician and the nursing team and you get on these side effects, somebody tells you with lung cancer, I am more short-winded, they are in my clinic or in the ER that day. And so you have to get them in, evaluate them fast, get them treated, and you can prevent fatalities. I do believe that. But it requires educating the patients and the family members to make sure that they understand that this is a possibility.
And Stephen, one of the problems with lung cancer is, if you want to start a drug and you want the patient to tell you if you get short of breath so you can jump over it and hopefully pick it up on imaging even before then. But the problem is these people with lung cancer generally don't have normal lung. They have tumor in there, they have chronic lung disease, cardiovascular disease. How does that factor in, Stephen? And what about if the patient already is short of breath just from these other causes? Will you consider TDXD if you have no other options?
Yeah, I will. I mean, it's the lesser of two evils there, and generally the greatest threat to a patient's well-being is the lung cancer itself, and I got to get that under control. Since COVID, I found that the home pulse oxes have become much more common, and so generally patients can tell me if they're getting hypoxic. We can monitor a little closely, and Now that we know lower doses of this drug are associated with much lower rates of ILD, in lung cancer, we're actually now using the lower dose than the original studies. And so with that, generally, I do find it pretty safe. We're looking for changes in the negative direction.
So Tara, we talked about the fact that this is really, even though it's targeted therapy, it's targeted delivery of chemotherapy. We hear from the breast people actually chemo side effects, nausea and vomiting, even sometimes hair loss. Do you see that in lung cancer?
Yeah, we do. I wouldn't say we have a large volume of patients that we treat with it, but I would say that and maybe even some neuropathy, fatigue, yes.
So to be continued, and we will continue tomorrow morning talking about acute myeloid leukemia, myelofibrosis, and MDS. Thanks so much to the faculty. Thank you for attending. Have a great night.